Thank you. Thank you guys for being here. Thank you for doing this. We're going to kind of go through buprenorphine in the pre-hospital setting, the why not, what are we going to do about it, and most importantly are the thank yous. I have no disclosures. Nobody pays me to do anything of this. No drug companies, anything. I will use brand names and generic interchangeably, and that's just the way my brain works. So I apologize in advance, but they don't pay me a dime. There's a huge team behind this work. So I am the talking head right now, but there's a huge team. And so most importantly, on the bottom is Con Whited, who made all the slides possible and is making this recording possible, which I can't do any of those things. Okay, so let's talk about our objectives for today. So the first thing is we want to describe some of the street trends and what I'm seeing in my patients that are being tested, so I can tell the community what's happening in our street supply. Okay, so I want to kind of update with that and kind of share with you guys some new trends that I'm seeing and things to watch out for. We're going to talk about some of the rationale behind EMS Bup. Why does this matter? Why are we doing this? Why am I adding something else to my skill set? Okay, and then we want to talk about who are the best candidates for EMS Bup in the pre-hospital setting, make sure we're really hitting those patients and getting them the care that they need. And then truly, so you get someone buprenorphine, you get them on that pathway to treatment, then what, right? And we have that for you. This isn't a solo game. Addiction medicine and taking care of patients with addiction is a team sport. And so we're going to introduce you to some of the teammates that you're going to be working with on this. And then I want you to be confident in this. I own it as an addiction medicine specialist. This is my niche. Like, this is where I have my superpowers, is connecting with people in that I'm sick as a dog. What am I going to do? How can I be helped setting? But I am terrible at other things in addiction medicine. What I really want you is to have that confidence of, I can do this. I know what I'm doing. And if there's any questions, I know how to get help. Okay, so those are our objectives. Okay, so what's the point? Why does this matter? Why are we spending all this time and energy on this project? And I'd like to share with you what we used to do, right? So what we used to do, or what still is done in many situations, and certainly across the nation, this is still what's happening, but EMS takes care of somebody with an overdose. Like, you come in, you give the Narcan, you save the day, you save the life, the family's scared to death, right? They go to the hospital. And I worked in the ER for 20 years, and we all know what happens, right? Okay, it's maybe a turkey sandwich, a giant dose of stigma, and get out. Okay, that's the standard of care. I had a patient say that to me point blank. I said, something about treating him with the standard of care, and he said the standard of care is to treat me like shit and to kick me out as quickly as possible. So I'm just being honest with you. That's what's happening. That's why we're trying to change this. Okay? And we'll come back to what that change looks like. So what is missing in that workflow was treating patients with kindness, with humanity, with compassion, and also offering them a chance at changing that spiral, right? They've been on the addiction, incarceration, unhoused status, maybe in and out of treatment, maybe back to unhoused, maybe back in and out of jail. Let's start making some changes in that circle. And so what if our EMS teammates, instead of, okay, I reversed the overdose, hero is here, right? Because that's what it is. Take that hero moment and take it to the next stage. This isn't overdose reversal. This is connection to treatment. Truly, and I say the word treatment because I mean it, right? This is not just I solved this immediate problem, but now I'm going to help you with the underlying addiction, the untreated use disorder, and actually get you on a path of recovery where you get your kids back and your family and your life, and right? So it's that treatment pathway. So we, our medics are able to initiate treatment for opiate use disorder right in the field. You don't have to call for base. You don't have to ask for anybody's anything. You have the education to do this. You don't need to ask for help. But if you have a question, you can. Now, I'm going to be completely transparent. Some of the docs you will call have less experience with this than you do. Some of the staff at the hospital will have less experience with this than you do. Less training, less education, and part of that is, and I can say this affectionately because I am an old dog, is it takes a while for old dogs to learn new tricks. Okay, you guys are getting the frontline education. This is not even the tip of the spear, but it's ahead of that. And not all of your colleagues are going to have that. So truly, if you get to the hospital or if you make base and what they're telling you makes no sense in comparison to what you're hearing and learning, you may have the most up-to-date information. I'm not asking you to argue because that's a waste of everybody's time. What I'm saying is advocate for your patient. We can talk about it. We review all of these cases, and we can help educate the hospitals and educate the staff because you guys are getting the most up-to-date information at this time. Okay? The drug landscape, when it was heroin, I mean, we tease in addiction medicine like, oh my gosh, bring back the heroin, right? Because that's actually when this was a lot easier. Well, many of the people in the hospitals trained back in the heroin days. Well, these aren't even now just the fentanyl days. We're in a different world. And so we have to adjust. And you guys are having that education, and you're able to move forward with this. So please, like, advocate for your patients. Make sure that you're getting across what needs to be done for that person. And I understand maybe you're going to talk to somebody that doesn't have this level of knowledge. Okay? And bring it back to us, and we'll talk to you about it. Okay. So the other thing that we talk a lot about is the COWS score, right? The opioid withdrawal score. And it's important because it's a powerful indicator of kind of where somebody was in their withdrawal, and then with treatment, where they ended up. And you'll see these scores. It's awesome when we're reviewing the cases. Some would go from 15 to 4. And well, what does that mean? It means they're no longer sweaty. They're no longer nauseated. They're no longer agitated. They feel better. And so we want you to document that as a way for you to see, I've made a change. I've made a positive impact for this person. Okay? So that's the other thing is obviously we want to document, we want to trend this information, and we want you to feel comfortable with it. So definitely those COWS scores. And then the other thing is in your documentation, that's all I get. Until my team meets the patient later or refer them to someone and they meet the patient, I don't have any other information on this case. So if you feel, if you're seeing something with a COWS score, if the patient's too agitated for you and you try to talk to them and try to do a COWS, but it's a no-go, document that because that helps us help you move this forward and make a difference for these patients. Okay, so one of the first things in our objectives is what's going on in the street. I end up with a beautiful, beautiful trusting relationship with a lot of my patients. And they will come into me and they will literally say, Doc, something's wrong in my dope. I need you to test me. I have no idea what I'm dealing with. And it's true. So we do the testing and we get back all kinds of random stuff. So I'm going to share with you kind of what we're seeing, the big highlights specifically. But we knew this was coming. We knew there was a change. Remember I said heroin to fentanyl and now what? Right? Kind of a thing. And you can tell that by the Narcan that's being administered in our community. Something's changed, right? And so you can see here, even in 2019, when fentanyl first came to our community, we were still using, on average, about 2 milligrams, almost 3 milligrams of Narcan per encounter. And you can see the trend over time to now, it's almost doubled. It's basically 5 milligrams per encounter, which obviously that's a potency issue as well. It's probably getting Narcan earlier in the community issue, but whatever it may be, things have changed. And this is what we're seeing with time. And I think this is part of the new stuff. So I've seen a sprinkling of carfentanil in our supply for about 1.5 years now. And that's just in my patients that are coming in and saying that something's wrong, right? Or we're testing them for other reasons. We do a lot of testing here for education for the patients. But now I had a patient, it's about almost 2 months ago now, that we were trying to do his transition onto buprenorphine. He hadn't gotten Narcan. He was trying to do a natural kind of transition. And it was really rough. And when I got his toxicology test back, he was using at the time about 16 to 20 of the blues a day. Okay? And traditionally, blues are thought to be less potent, less dangerous than powder fentanyl, right? Than the ISO, clean, all those things that are on the street. Unfortunately, when I got his toxicology back, there was absolutely zero fentanyl in his system. There was zero norfentanyl in his system. Norfentanyl is the metabolite. Nothing. And it was only carfentanil. So those blues that are in his supply are 100% only carfentanil. which scares me to death. Because my kids, and I say the children that we get to take care of, our kids, 14, 15, 16, the word in their circle is that it's just a blue. It's not. And this is now. This has happened in 2026. I'm working with this gentleman. We're working really closely. He and I are working with the DEA to figure out what we're going to do with this insane supply that we have now. Okay? So this is here. This isn't like, oh, in New York, there's no. This is Monterey. Like, this is my patient right here in our county. Okay. The other thing that's coming up a lot right now is kratom, right? 7-OH. This is a huge thing. I think in our world, if it looks like an opioid overdose, it is. If somebody's telling you, oh, I only use kratom, awesome. But looks like an opioid overdose is an opioid overdose. Reverses with Narcan, whether they say they're using kratom or not, is fine. Okay? Kratom, as you guys all know, has opioid and stimulant effects. So it's kind of like the speedballs and back in the day, a little up, a little down, right? You got it all mixed in. So that's how it kind of works in the brain, and why you'll see really variable responses with kratom. Really variable. But thank heavens the opioid component of this does reverse with naloxone. Okay? And it responds beautifully to buprenorphine. I have a number of patients that we've gotten off, heroin when that was the day, or if they still believe they're getting that, and fentanyl, that have been told by a friend, air quotes always, that kratom is the answer. That'll help them. Well, and then now we get off kratom. And how do we do it? We do it with bupe. So it's the exact same treatment. If it looks like, a horse, it is, regardless of where what etiology the chemistry was. Okay, anybody that is running calls at the prison is very familiar with spice. I didn't realize how big of a deal this was in our prison population until I started doing this work. Like, you guys run a lot on spice calls, okay? Same thing. Pinpoint pupils, unresponsive, poorly breathing, you go for the Narcan. Spice is one of those drugs that it's just so variable, right? You'll see some response, you won't. We're kind of back to the contamination or the adulteration or the mixing of drugs what's in their system? I have no idea. But if they look like an opioid overdose and you reverse them with Narcan and they do well, they may as well benefit from buprenorphine. It's the same story. Whether it's I'm using spice, whether it's I'm using kratom, whatever it may be. Okay? So just so we mention that, it's wild to me how much is in our prison. I talked with the medical director and I was like, I know, you guys have all this spice. Like, it's just wild what is brought into specific populations. And then the last thing I want to bring up as far as the street drugs, when fentanyl hit our community in 2019, I went back in the coroner's records, and I've been an agent of the coroner's office since 2016. I have records back to 2015 because that's when they switched systems, so I have all the records, the access to those. And so when fentanyl came, I was like, what in the world? And I went back through my notes. And we've had fentanyl, and again, it's like a sprinkling in our supply since about 2015. And it was like 5 cases, 3 cases a year, just tiny little under the radars. And when I pulled the prescription drug monitoring program, I was like, fentanyl? That's not on their prescribed medication list. And this is why, right? So it's been kind of smattering in until people got really good at it, and it became a lot cheaper in 2019. But in the coke, I still see it in the coke all the time right now. All the time in the coke. Meth kind of goes up and down. There was a period about a year ago that if you were using meth, you were using fent in our community. Story over. Now it's a little different. Most of my patients that are their drug of choice is meth have converted over to rock form because it's harder to contaminate or adulterate the rock form with fentanyl versus a powder form. I mean, it's really interesting what people are dealing with. But currently I do have some patients intending to use meth only that are actually showing up positive for meth only right now. Coke is different. Coke is still pretty, and again, it's probably the powder component of it, right? It's just so easy to mix. I tell the story quite frequently. I had a patient on bupe. He was on the injectable, and he and his brother did some lines of coke down in South County, and they used their coke, and the brother just went down. And my patient, because he was on buprenorphine, didn't, right? And he was unaffected enough that he was able to run to the car, grab some Narcan, save his brother's life, call 911. But in that time, the overdose was so significant. The young man survived, but it was an ICU stay. It was a prolonged intubation. Like he had some significant, brain trauma associated with that overdose. So what that says to me is if my patient had gone down, that's 2 bodies. And if my patient hadn't been able to get Narcan and hadn't been able to do all those steps that I said, that young man would have suffered an even worse consequence. So just keeping in mind, I talk to my patients all the time. We had 3 last month of, it was Coke, but yet they, I only use Coke. And that's what this is about. I mean, I don't even use opioids. How often, right, do you hear that? And yet, looks like an opioid response to Narcan is, and we move forward with treatment. Or at least open the conversation. I say to my patients all the time, I realize fentanyl is not your drug of choice. I realize you actually hate fentanyl. My patients say that to me all the time. They're so over it. But we have to deal with what we have. You can't get Coke without fentanyl right now. I mean, I'm sure you can, but you know what I mean? So just having that open, honest, non-judgmental conversation. Okay? All right. Okay. So the meat of it is, so how does this involve me again? And I was telling a story earlier about when, we were moving our practice, how does this involve me? Well, this is how it involves you, because that's when we all start caring, right? How does this make a difference for me? And truly, there's 2 giant buckets. 1, we are in the job of treating pain and suffering, okay? If I can make someone less uncomfortable, less miserable, if I can give them that gift of relief, that's 1, okay? So right here, less vomiting. Dr. Hearn will talk about if you don't want vomit in your rig, give buprenorphine, right? There are a number of ways to look at this, but pain and suffering, that's how I look at it, okay? So you are treating their withdrawal symptoms. You guys have all seen opioid withdrawal. It is agonizing. You're crawling out of your skin, you're cold, you're hot, you're nauseated. That is agony. And I have said, and I will say it again, that if I am in opioid withdrawal, if I am in that misery state, and the only thing that's going to relieve it is an opioid, sign me up. I am not going to suffer like they suffer, right? So treating pain and suffering, that's kind of our thing, long bone fracture, stabilization, that's what we do. So please, then here's the beautiful part. That dose of buprenorphine that is given in the field, even if a person never takes buprenorphine again, they are less likely to die in the 24 hours from that overdose. You have given them an opportunity to survive the day. Because if I'm in that agonizing opioid withdrawal, and I know scoring fentanyl is going to make me feel better, that's where I'm headed, right now, okay? What is my risk of that use, okay? So, and I have the numbers and I want to make sure I don't misquote. Truly, I want to make sure that you guys have, where did they put it? I'll pull it up and add it in. I'm almost positive, and I can pull this up. One of the studies found that 8% of people that have an opioid overdose reversal, okay, Narcan administration, 8% will die in the first 3 days, okay? And then the remainder of the people that go on to die, it's another 6%, I think, that will die in that first year. So if you think about myocardial infarction, right? 4% per year is kind of the standard average that we hear. It's pretty staggering to think about this population, okay? And keep in mind, these guys are young. This is a young, otherwise healthy population. And so those lives saved have so many years of life in front of them, okay? So that's the other thing, is it's going to prevent that overdose for 24 hours. Now, maybe that'll give them some time to think about what they want to do. Maybe it'll give them some time to connect with treatment. Maybe it'll just give them some time with a little more clear thinking. Okay, so number 1, you're treating pain and suffering. And number 2, you're saving life here and forward. So it's pretty amazing. And then the other thing is every time this person overdoses, there's potential not only for death, but just damage. I mean, you think about it, and I get to see these patients now, and we talk about it affectionately and respectfully with one overdose too many, right? That, Bob, it's my nickname for everybody, but Bob was never the same. after his last overdose, or Bob was never really able to keep a job after his last run, right? So it's preventing that damage and that trauma from repeated overdoses and saves, as you will. And then the other thing is, and Ben and I talk about this all the time, is when someone's agitated and they want an AMA, how much of that is just the withdrawal? I told you, they're super uncomfortable, they're chilled, they're achy, they're climbing out of their skin. I'd AMA too. If I had to go to the hospital, forgive me for being honest, deal with the stigma, deal with the eyeballs on me, oh yeah, he's here with an overdose, right? Or I can just go get what I need to feel better, I'll be AMA for sure, right? What's the speed, what's the timing on dealing with the hospital and the judgment, most likely, that you may receive? We're trying to fix that, but we're working, versus just go get what you need and feel better, right? Okay, so many of the AMAs that we review, we feel may have benefited from being offered treatment and comfort. And you can even say to the patient, this is something we use for treatment. I'm not saying you have to go to treatment. I'm saying I want you to feel better, right? I want to give you this comfort. And so that time frame may be when that person considers, like, dude, I am over this. Like, I can't do this anymore. And maybe it's time to actually maintain treatment. So they may be ready to get that help. Okay, so what we find when people are in treatment and offered these services is obviously repeat overdoses go down because they're no longer using the full agonist opioids, and they're actually preventing further overdose, further exposure, okay? And then as well, you're opening that door for, are you ready for some treatment? We're not committing you to 20 years of methadone. We're saying, do you want to try to do something different today? And you're opening that door for them, okay? And think about the trust that comes with that. Like, instead of, here's your Narcan, I know you're miserable, sucks to be you, right? Let's get you to the hospital so you can deal with that circumstance. It's like, hey, I want to advocate for you. That provider-patient relationship of you matter enough that I want to help you is something these patients have never experienced, right? In a medical setting, I will never forget one of my patients. He said to me months into our relationship, he was like, thank you for making eye contact with me. And the fact that that stands out to him as something worthy of acknowledging is immense. But it's true. So if you take that minute, you take those few minutes to say, hey, they have some treatment for you. I can make you feel better now. I care about you. You matter. It's mind-blowing for this population that has been pushed aside for so long. Okay? All right. Okay. So this is where I get to share with you what we've done so far. It's pretty cool. So we have administered 48 doses, or 48, we've taken care of 48 patients with buprenorphine in Monterey County since we started this program. That's 48 people that got this kind, patient-centered comfort and connection to treatment care. It's pretty awesome. Okay? And so as you can see, when we started out, we were a little slow with it because it's a new thing, and I've already mentioned old dogs and new tricks, and it takes us some time. But as you can see, we're really increasing. And this is basically the patients that may have been eligible. This gets back to your documentation, right? If you document really well, then I know, was this patient eligible or not? But these are patients who may or may not have been eligible, but we think they might have been, and they did receive buprenorphine. So it's starting to happen. We're starting to make those interventions. And then this is the win. This is totally the win. So we go back on all those cases of EMS-administered buprenorphine and what happened. So you gave that first dose. You opened that door. You helped them with comfort. You showed that person that this will help them. 78% of those patients go on to continue treatment. And it may not be 20 years of methadone, I'm hearing you. But they went on to continue. They had to make it to a pharmacy. They had, right? They had to go through all those barriers of medical care, but they did it. That's incredible. Like, of each of the 4 patients that have been treated, 3 of those patients continue to follow up. That's insane. That's the mic drop. And my phone goes off, but that's different. That's the mic drop, okay? This is what your interventions have done for this population. So awesome. Okay, so now you've given the buprenorphine, you know it's gonna matter, you know it's gonna help them connect to treatment. Well, okay, so how does that happen? And that's our substance use navigators. Affectionately called the sun. That was really smart. Whoever did that was, yay, it wasn't me. But the substance use navigator, those are our teammates in the hospitals, or we have our street teams that act in the same way, that does that warm, not just handoff, but that warm embrace. How can I help you? What can I do for you, right? So our substance use navigators are key, and here's the two at Salinas Valley. This is Guillermo, and this is Lauren. They're amazing. And truly, it is a warm embrace. It's not a handoff. It's absolutely a, I got you. How can I help you? And if somebody is not ready for treatment that day, it's okay. If all somebody wants is, how do I get information on where to get safe supplies? Totally cool. If it's, hey, can you just help me with some housing stuff? That's cool. It's whatever that person is ready for in that moment is yes. And that's how we all operate. And if a patient doesn't make it to the hospital, we will help catch them. So we have a substance use response team that literally responds to the street. I'm on that team. And we just go in like, hey, is there anything we can help you with? Do you need more Narcan? Do you need some supplies? Let's talk about treatment or not. Whatever they want, we're there for them. Okay? Because they may not be ready today, but they may later. One of my patients, it was 6 weeks that I saw him in the clinic. Every week, I'm like, hey, how are you? I'm good. And 6 weeks later, he's like, can we talk? Absolutely. And, in treatment ever since. This is why I do what I do. It's so cool. So the substance use navigators don't just, you have to do buprenorphine. Oh, come on, right? It's any of it. Do you need help with shelter? Do you need help with getting your Medi-Cal? Do you need whatever? They help them navigate a very broken system that we're all aware of. Okay. And then truly, this helps that recidivism, those return visits. They have somebody that's helping them navigate the system. They don't need to, they're less likely to go out and to use and to overdose and to that frequent flyer thing that we all are very familiar with. So if we change how it is from what it was, right? You get your overdose reversed, you go to the hospital, you leave, we'll just leave it there. This is different now. So we're stabilizing the withdrawal symptoms, making you feel better, okay? Starting you on treatment. Hey, this is what treatment feels like. This is what it feels like to not be sick. This is how you can feel. And then that trust, like there's a healthcare provider that actually, I got you, right? So that's where we're changing it. They go to the ER and they meet our substance use navigators, and that sustains that trust and engagement. It's that warm embrace. Hey, thank you so much. Now I got you. I'm here for you, right? And then they can connect them with services. I mean, how many of my patients use because they live on the street? Like truly, if I'm living in my car, checking out doesn't sound awful. Well, checking out enough times, here I am, depending on fentanyl and overdosing, right? So that connection may be how we break this cycle. And then the navigators connect them with us, which is another embrace. I mean, when you walk in our clinic, it is like you were going home. Hey, how are you? Oh my gosh, what's going on? You want to color? Let's. It's really fun. So we are connecting patients to further connection to care. Okay, and that's not just our clinic, but that's across. That's what we're all trying to do, is to get people the services they need. Totally different. Okay, all right. Okay, so what we feel, and always open for ideas, but what we feel kind of maximizes this pathway is really making sure we're all on the same page, right? So recommending some services, well, if they're going to the hospital and they're expecting to be judged and kicked out fast, right? You can help them with, hey, there's going to be somebody there, or if it's after hours, somebody's going to reach out to you. It's Lauren. Guillermo's going to reach out to you. Hey, this is Guillermo. Hey, Guillermo, we got somebody here we want to have you come talk to, however it is, right? Prep them. Let them know. Like the ER can give you a prescription for this medication when you leave. There's a substance use navigator that's going to be reaching out to you. Even if they're not in hospital right now, they're probably going to call you to follow up. There's a team to treat you and help you. So just setting that framing, like this is what we have to offer if you would like it, right? So you can set that up right from the beginning, and that helps the next member of our team move forward, okay? Now, the other thing is that documentation I mentioned. Put down your cows, put down your thoughts, share with us what you're thinking and seeing so we can help make this better, okay? And then the accurate handoff, I'm the person that, and Ben and I specifically are following up every one of these cases. And you'll read the ER doc note, like patient received buprenorphine in the field. We'll make sure they have a buprenorphine prescription on release. Yes, that's the win, right? Even if the patient doesn't pick up that prescription, it's available for them. And they know that somebody was trying to help them, which is different than most of what they've ever experienced. So yeah, making sure that you let them know the patient was in really significant withdrawal. We gave them buprenorphine. Their cows went from 15 to 4. You're kind of prepping it like, hey guys, can you do this? Right? I when we were starting this project, I would tell my ER docs, like, oh, I can't start buprenorphine. I'm like, we can start it in the field. How come you can't? Like, what is the problem? Right? So just kind of putting it forward. Hey, we did this. We started this for you. Please take it forward. Okay? So, and then as well, making sure that you're letting them know what happened kind of reminds them to continue the treatment. And I already told them one of the substance use navigators, would be possibly contacting them. Then maybe that nurse or that physician that's seeing them is like, oh yeah, substance use navigator. Right? We're kind of moving forward for the team. Okay. So now here comes the confident part, right? We went through all these different things. Okay. Buprenorphine is the most amazing medication I have worked with, and there is some nuance. And that's why we do training, that's why we talk about it, that's why we want to make sure we're all on the same page. There is nuance to giving someone morphine, right? Drops your blood pressure, can make you super itchy, make you altered. You guys are familiar with medications that have great benefits and also have some challenges. So this is nothing new, okay? So if you think about it this way, so here is an empty opioid receptor. When carfentanil came to our community, and then when fentanyl came before it, right, our patients have gigantic upregulation of their receptors, okay? That's why the withdrawal is so severe and so prolonged. So when that receptor is empty or blocked by Narcan, but basically it does not have a native opioid on it, or a full agonist or partial agonist, they are getting all of those withdrawal symptoms. The piloerection, the nausea, the vomiting, the chills, the aches, the whole thing, okay? So it's an empty receptor. If the patient has a full agonist, so heroin, morphine dilaudid, whatever, right? It binds that receptor, and then they have then they feel back to normal. And many of my patients haven't been high in years. They only use to stay well, is kind of the vernacular that we use. But that alleviates the withdrawal. But frankly, if they go back out and use fentanyl, or they go use a full agonist opioid, we just stay on this road, right? The flip is buprenorphine, which binds that receptor and it partly activates it. This is why I love this medication. It treats withdrawal, it treats cravings, but it doesn't cause respiratory depression, overdose, and death. Okay? The other thing is because it's prescribed by me, right, or by a physician, is we actually know what it is. Because when I talk about what's being put in the supply, if you're getting it from a pharmacy written by your doctor, you actually know what you're taking versus what your buddy gave you or the blues that are on the street or whatever it may be. And what I find, and you can share this with patients that may have some questions, because there's the whole, it's exchanging one drug for the other, which is one of the arguments, makes me more angry than most. This allows the brain to heal. So I mentioned that upregulation, right? If you're using heroin and then without heroin you don't feel normal anymore, you start feeling unwell, right? Your body has upregulated your opioid receptor, so you need more opioid to feel normal, right? Well, then you magnify that by having fentanyl. And now you magnify that by having carfentanil. I have patients, their tolerance is just I can't understand it. What's crazy is when you start treating them with buprenorphine, it goes down. They start healing. That upregulation reverse this, right? So I have patients that literally was taking 5, 6 of the 8 milligram buprenorphine to feel normal in the beginning, to feel well. And I know it's not FDA approved, I understand that. But huge doses to feel normal initially are now like, yeah, I only need maybe 1 or 2 a day now because their brains are healing. It's wild to watch, but this is what I do all day. So you can see here, it helps the symptoms of craving and withdrawal, but it doesn't result in overdose and death. And it also starts the process of brain healing, and that upregulation is reversed. It's amazing to watch what patients go through. So with that though, can bupe precipitate withdrawal? Of course it can. It is not a full agonist. So if your brain, currently all of those receptors have fentanyl on them, and you give buprenorphine, it will literally rip off the fentanyl and bind, but it only activates partly. So for them, it is a relative withdrawal. It absolutely is. Okay? That's why we want that COWS positive in someone in withdrawal before we give it. Okay? But so what do we do if someone gets bupe and gets worse, so they go into precipitated withdrawal? What do? We give more bupe. That's actually what we do. Because if you saturate the system enough, those symptoms of withdrawal will be treated. Okay, it's wild and it is hard for patients to kind of buy into, but when someone tells me, they're like, yeah, I got bupe and I got more sick, I'm like, okay, so you don't have enough. I got you. We got to get more bupe in your system to get you over that hump. Once somebody's gotten a certain threshold of bupe in, that's the only choice. Like, really. And I tell my patients, I'm like, all right, you and I are off the cliff. Let's do this. And this happened about a month ago. Someone was at a treatment program and they had received 8 milligrams of bupe early. And so they were in precipitated withdrawal. They were in a worse withdrawal state. And so what did our medics do? They gave them more bupe. And guess what? They were better, right? That person required really high doses of bupe. So I'm imagining where their upregulation was, but that's the treatment. So yeah, okay, we precipitate withdrawal, give them more. You will help them feel better. And you have adjuncts, right? You can give them Zofran if they're more nauseated, in the hospital. We'll do clonidine, hydroxyzine, all these kinds of things. So yeah, that's how we make people feel better. Okay, now what if they AMA? What if they aren't ready for bupe, or they do take a dose and then they want to leave? We follow up those cases as best we can. I would ask if you can to get a phone number, a location where this person tends to be. We'll try to find them and see what they need. Not, we want you to get into treatment. How can we help you? Okay. So if the patient, refuses treatment or care, if you do a COWS and you offer them bupe, at least you've opened that door and let them know there's somebody that cares for them and is a provider that is willing to offer them treatment. Maybe that's the first step for them. I don't know. But please document it so we can follow up and help however we can. All right? Okay. I mentioned we are above the tip of the spear, but we're all still on the spear. Like, we are not doing this in a vacuum, the only place in the world that's doing that's not how it is. This is already published. Dr. Hearn is one of the California Bridge gurus, buddy of everybody, as well as Dr. Herring, and then Vanessa runs the show, right? This is their write-up that they put through on some of the EMS work that has come out of California Bridge. We are part of that team. I'm part of the learning collaboratives. We meet with them monthly. We follow up with all the groups kind of in the region that are doing this. We're learning from each other and we're building it together. So you are not doing this by yourself. You're not in the middle of nowhere. This is evidence-based treatment that is happening across the state. It's new, for sure, because it has to be. We didn't have this problem. Fentanyl wasn't here 20 years ago. So evidence-based care for sure. We have the protocols for it. You guys have all seen it. You've got your medical directors on board. He gets emails from me almost every day. And you've seen our local outcomes. You've seen what we're doing. So there's no reason to hesitate because it's new. Yeah, it's new, but it's evidence-based and it's got a lot of support behind it. And then this is the important thing though. You are treating the patient's symptoms. You are helping them towards their recovery. You are not telling them anything they have to do for their long-term treatment, but you're opening that door for their care. Okay? And then The enabling thing blows my mind. You know, there were some places initially that wouldn't allow us to put Narcan because they said we were enabling people to use. We're like, no, we're enabling them to survive. Yes, we're enabling them to live. That's what we're enabling. You're right. So just keep in mind, this is a process for this patient, and it may not be the first, second, fifth, 10th time that it makes a difference. But if they die in any of those times, there's never a chance to recover. So, yeah. All right. Okay. And this is why I personally, and this is very well supported in what we do, is withholding Bupe, not offering it, not talking about it, is a lot more risky than moving forward and offering it to that patient. Okay? And they can decline. That's called autonomy. We're all familiar with it. But at least this is the safer choice. Okay? All right. Okay. So when do we give it? You guys know this, right? You've all seen the patients that are suffering with opioid withdrawal. I personally, when I'm telling people on the street about withdrawal syndromes, I talk to them a lot about objective. The yawning, sneezing, that's a big one. Like, that's a huge one, right? If somebody's yawning, sneezing, piloerection is another huge one. I see patients in the jail all the time. Super, piloerect, chilled, achy, yawning. It's like, oh my gosh. So the objective ones are a lot easier. There's a pretty significant anxiety component with this process. And I acknowledge that, right? And so some of the restlessness, the anxiety associated with it, that may be from a lot of factors. But truly, keep in mind your objective signs. Watch for the runny nose, piloerection kind of stuff. That's kind of your first indicator that this is a good time to consider buprenorphine. But you guys are very familiar with all of this, right? Okay. All right. And then we have our eligibility criteria. It's right there in the guidelines and in the protocols and policies that we have, 4520 if you're looking for it. With or without naloxone, you can administer buprenorphine. Okay? It's all about the cows. It's all about the clinical scenario. Okay? And we've had a number of patients that they were in natural withdrawal for whatever reason. They were in a program, and the program medical director wasn't available to give them bupe or whatever it may be, that they were in normal withdrawal or natural withdrawal. So either way is fine. But we'll go through the cows in just a second. You do need somebody that's alert enough to give consent for this. Just verbal consent is great, but you want to have that conversation, right? 16 and older, any 16-year-old that wants to start buprenorphine, I can give it to them without even a hesitation. And so we have the same for the policies here. Like parental consent is required 15 and under for me, for my patients. So everybody's on the same page there. And then this is one where we find a lot of patients kind of fall out of the options, is somebody who has had, or who's in the middle of a medical or a trauma-related emergency, right? If you think I'm septic, let's just get to the hospital. If sepsis is complicating my opioid withdrawal, we'll figure it out, right? So if you're concerned about that, or I see them all the time, motor vehicle accidents, assaults, if you just feel there is too much on the table to add in this treatment, fine, just document it. That's all we need to know, okay? And then when somebody's considering AMAing, I would put this as a higher priority time for the conversation. Because are they going to AMA because they feel like garbage because they're in withdrawal? Take that opportunity, if you can, to offer them buprenorphine, and that may help with the fear of, oh my gosh, I've got to go, I've got to find my supplier, I've got to go, right? You may help them understand there's an alternative. Okay, and then I've got your policy is listed there. We'll run the cows really quickly. I use MD Calc all the time for various things. It's a great tool. You can use it right there on the scene. And you can show even the patient, you can show your partner, your colleague, fire, whoever's on scene with you, kind of what you're seeing. And this objectifies it. Like, I have a cows of 16. Cool. I give them bupe, I have a cows of 5. Cool. Right? You can confirm that. It's just really helpful, and truly, MD Calc is what I use all the time. All right. And then we'll wrap up with some stuff here as far as the patient decision making. It's a team sport, like I said, so bring it up to them. Your confidence level is going to come through, helping them understand kind of what has happened, respecting their autonomy. And then as someone who worked in the ER for about 20 years, on the scene, there's the overdose situation, they get the naloxone, they're in acute withdrawal. In that moment is the absolute best, cleanest, safest to give buprenorphine. 2 hours later, when they're still in an ER hallway bed, some of that fentanyl has rebound those receptors. That door has closed. They cannot give them bupe in that moment. So if you think, oh, they'll just do it at the hospital, no big deal. Number one, they may not, period. The doc, the staff may not be comfortable enough with it. But number two, the window may have closed. Okay, so just keeping in mind that timing is really important. You guys have the best moment for this. Somebody's COWS is high, they just got Narcan, you know, because the binding, fentanyl binds, Narcan binds tighter, okay, because it pulls it off and binds, you guys know that. Clearly, bupe actually binds tighter. So it pulls off the Narcan and binds. And then the fentanyl, the fentanyl is still around, unfortunately, but the buprenorphine still binds tighter. That's just the affinity for the receptor. Okay, and then you guys know you do not need to call for medical backup, but if you want to, please do. All right, okay, so I was supposed to be able to get a video of my patient yesterday, and I was not able to. It was a bummer. He's been sick, so he wasn't able to do it. But we have some pretty amazing patients, and I can share. It's awesome to see the people that you guys have helped and the differences in the lives that have happened. I have a number of patients that AMA'd from the scene. They got bupe and left. They're mine. Connected. Come in, we hang out. They're met with a warm embrace in our front lobby. They're part of the team. We're helping them move forward with their lives, working on their education, working on their housing. Like, these are the people that you guys are taking care of and making possible. Okay? And even if somebody's struggling, that warmth and that connection to treatment, it's pretty powerful.
My name is Michael. I'm a 43-year-old from Santa Cruz, California. I'm a college graduate, worked as a compounding pharmacy lab tech for 5 years, then a traveling pharmaceutical sales rep for 10 years. I developed an opioid attachment after a devastating motorcycle accident. Overindulging, overprescribing, and not covering my butt got me to the place I'm at today. Addiction is a tricky foe, cunning, powerful, and unpredictable. I ended up losing my marriage of 10 years, my daughter, and my career to it. I thought I could do this on my own without the crutch of MAT or a doctor's help, but I struggled for years being closed-minded. So, fast forward to recent times. I'm in trouble with the law and forced into withdrawal. I end up needing medical help through EMS and a transport to the hospital. The EMS personnel noticed my distress with the withdrawal and asked if I've ever taken bupe before. I said no, and everything changed from there. Meeting Dr. Close shortly afterward changed everything. No one in my life cares more than her about the well-being of her patients and understands the crucial necessity of bupe in all aspects of addiction recovery. In particular, having EMS trained to administer to patients at that critical point is a lifesaver, and it changed my life that day in the back of the ambulance. With the fight against deadly street drugs, that's one more tool in the arsenal on our side.
And this is the bottom line. This is the opportunity that you guys have that nobody else does. Even when I'm out there on the street with patients, I'm getting them in the I just used, and I don't know if I'm ready for treatment or what I want to do. I'm kind of in a little bit of withdrawal. I don't know what I want to do. You guys get them in the I am just in that ideal situation that I can receive treatment and start my care. So please, this is a time to make impact on those lives. Okay, you have access to this. This is the California Bridge information, right? They are updating it. They're learning as we're doing this across the state, right? We're learning different things. The methadone grace period has changed. The most recent, this is April 26th, like this right now. The methadone is 72 hours now. And to talk about methadone, it's because it has that long half-life. As I said, a receptor that has fentanyl on it, if you rip that off and put on buprenorphine, it can put you into precipitated withdrawal. Because methadone lasts so long and it's full agonist, so there's a lot of those opioid receptors. You need at least about 3 days for enough of the methadone to be gone for the buprenorphine to make them feel better. So it's just the thought that we're going to potentially precipitate withdrawal. There is some jury out on that, but the timing's changing because of what we're learning in the field. So methadone is changing in that regard. And then the protocols, as you can see, they added kratom to the protocol, so we're keeping this updated all the time. So again, you are supported in doing this work. All right. So our final takeaways, okay? So obviously bupe, it's crazy safe. I mean, you cannot overdose on bupe alone, cannot. If you mix it with alcohol and Xanax, if you can get it at Xanax anywhere, but if you mix it with all kinds of stuff, of course you can overdose. But bupe alone, the answer is no. It has a ceiling effect. I've had patients take 72, 80, 90 milligrams. There's a study on healthy volunteers that took 90 milligrams. Nothing. It has a ceiling. Okay, so super crazy safe. It's incredibly effective. Even outside of the EMS bupe setting, for every 2 patients I treat with buprenorphine, 1 stays in treatment. 1 stays connected to care. There is no number needed to treat like that in anything in medicine. So it's amazing. You can see our local work here, and it not just saves that person in that first 24 hours, but if they're connected to care, you may have changed the trajectory of their life permanently. So. And then just my gratitude, again, to the whole team that does this work and everybody behind it and willing to take a chance and learn and be the tip of the spear. I just want to say thank you. So, thank you.